Hello, everyone. Welcome back to Karan Academy. My name is Karan, and today we're going to be talking about acute coronary syndrome, or ACS, angina, and the whole spectrum of ischemic heart disease. Again, one of the most high-yield concepts that you'll be coming across this year, and really, really important to understand how to pick these up, how we differentiate different acute coronary syndromes, and then knowing the mainstays of management inside out, I think would be super important. Now, this is a really important topic to know inside out. It's one that's commonly assessed, it's one that you'll commonly see, and it's one that you should understand in terms of why does it happen, what leads up to this, how do we diagnose it, and how do we treat it. So starting off nice and easy, I think it's really good to establish some core definitions before we move on. ACS, or acute coronary syndrome, by definition, is an acute, pretty straightforward, deterioration or cardiac hypoperfusion. What this basically means is that in the acute short-term setting, we have something that has caused the cardiac myocytes to lose a significant amount of their perfusion capacity, which means that our heart cells or our myocytes are basically not getting enough oxygen. And as you can imagine, if they don't get enough oxygen, they're going to eventually undergo different forms of ischemia. So ranking this from something that's not acute, more so chronic, is stable angina, and it's quite prevalent in our community, to the most severe form, which is a STEMI, or a ST elevated myocardial infarction. So one of the common questions of understanding this is, well, how do we differentiate between them? And we'll talk a bit about how they present, but it's really important to know from a diagnostic perspective, what do you do and how do you differentiate them if you have a patient in front of you? The first thing that's going to happen is you're going to have a patient coming in complaining of certain signs or symptoms that make you think, could this be a heart attack? This could be crushing chest pain, atypical presentations in women, pain radiating down the arm. They might have signs of hemodynamic instability. And you think this might be an ACS. And that's the first most important step. The next thing you need to do, and I can't stress this enough, is ECGs and TROPS. These two tests are going to provide you with a lot of information that's going to be really useful in a second. So because this is an acute presentation, this by definition cannot be stable angina. As the name suggests, stable angina should be stable and chronic. The first thing you're going to look at is your ECG. Now, if the ECG has signs, if the ECG has any ST elevation or elevation of the ST segment in concurrent leads, then pretty straightforward. This is an ST elevated myocardial infarction. If not, it doesn't necessarily rule out an ACS. You can still have an NSTEMI or unstable angina. In this case, you will look for other signs of ECG changes. This could include bundle branch blocks or even T-wave inversions, indicating cardiac ischemia. And again, it's important that you're looking in concurrent leads, and we'll get to this in a second. And once you do this, you then would look at your troponin levels. Now, differentiating an NSTEMI from unstable angina can often be quite tricky, but a key point is the TROPs. Now, with NSTEMIs, we do tend to see a significantly elevated TROP level, and this can still happen in unstable angina, but its severity is usually greater in NSTEMIs. This often also sometimes correlates to the severity of their presentation. Is this a really 10-on-10 crushing chest pain that they describe as the worst pain of their life? Or is this more so a 5-on-10, it feels like something's not right, so they came and had it checked in? Obviously, you're going to start off by taking a really good history, and that's really crucial. And part of that is going to be assessing their cardiovascular risk factors. Now, this is something that's going to come up time and time again, so I would recommend having a good understanding of this, and we can broadly split them into non-modifiable and modifiable ones. The modifiable risk factors are really important, especially when we talk about their prognosis down the track. After discharge or with their GP, it's really important that these risk factors are managed and controlled. So high blood pressure, high cholesterol, diabetes, PVD, and some of these most patients might have some of these. So it's about controlling them and managing them, and also ensuring lifestyle changes. I know pathophysiology, most people aren't the biggest fan of pathophys, but I think this is one of the few conditions for your level of understanding that you need to know the pathophysiology of inside out. So let's talk a bit about what's going on here. We start off with damage to the tunica intima, which is the innermost lining of your arteries or your coronary arteries. This is often due to disruptive or non-laminar flow, which can happen with increasing levels of cholesterol or damage to the actual intimal layer. What happens is once you have some slight damage, you have inflammatory cells because you have ongoing inflammation. These inflammatory cells engulf LDLs, which may have already been deposited. So this kind of creates a snowballing effect where you have more inflammation, more LDLs, more inflammation, and eventually end up developing things called fatty streaks. And surprisingly, most people in their 20s do tend to have fatty streaks. So this is a really early onset actual pathophysiological change. And unfortunately, some of you listening might also have some yourself. So really important to focus on your overall health. Gradually, we have this layer of deposition that thickens. And initially, it doesn't tend to cause a lot of symptoms. But as you can imagine, with a pipe, the more we constrict the lumen or the actual space through which blood flows, the more symptomological the patient is going to get. So as you have a thickening and reduction in the size of the lumen, you start off by developing something called stable angina. This is because, much like a garden hose, if you're resting, you should be fine. But when you start exercising, where you have an increase in the demand, your arteries can no longer cope with this increased demand. And this often causes some slight relative cardiac hypoperfusion. This causes the chest pain that most people describe as pain that starts off when they exercise, but eventually gets better. It gets better because there has been nothing acutely wrong that's caused a heart attack kind of picture. This is because they have something called a fibrous cap that prevents this layer from rupturing through. However, as the depositions increase, you can actually have the fibrous cap rupture. So once this happens, all the LDLs and the foam cells and all the inflammatory cells leak out into your artery. And because they are procoagulatory, they tend to have a snowballing effect of procoagulation and form something called a thrombus or a clot. Once you have a clot, that's when you go into your acute coronary syndrome picture. So let's recap. So stable angina, you have a bit of atherosclerosis, it's a fibrous cap. I would rate this a kind of 3 on 10, 4 on 10 kind of presentation. You have predictable chest pain that gets better with rest. Unstable angina is when you have significant vessel obstruction. However, this differs to stable angina because it typically does not get better with rest. However, it's not as bad as an NSTEMI or a STEMI because the size of the clot or the degree of thrombus formation is not going to be as severe as the other two. Now, NSTEMIs and STEMIs are very similar in pathophysiology. The key difference being how much of the lumen is actually occluded. If you have a full occlusion, that causes that's an NSTEMI. If you have a full occlusion, that's a STEMI. If you have a partial occlusion, that's going to be your NSTEMI. That's going to be your NSTEMI. Oops. Also, the other important thing is being able to localize as to where exactly or which one of the arteries has been particularly affected. And this is where the concept of congruent chest leads comes in. We, while looking at the ECG, might notice some changes in certain chest leads, and you have 12 of them. So you need to identify which area of the heart is undergoing that ischemic change. We have quite a few leads, and here's a good table summarizing them. That by looking at certain leads and seeing where you have those changes, you can identify with the concordant chest leads which of the areas and which artery supplying that area has been affected. And that's really important when we talk about imaging and percutaneous coronary interventions down the track, where we actually might go in and try to retrieve that clot. It also gives us a good estimation of what their prognosis might be. If you have a clot in your left anterior descending artery, that's often called the widowmaker because it has a very poor survival rate. Only 12% of patients who have a full STEMI to their LAD survive if the infarction has happened out of hospital. And that's obviously not a very high number. So what are the diagnostic tools we can use to come to a diagnosis? So ECG is going to be king. while talking about T waves, you might have heard different things about what the T waves might look like. If you go back to our first lecture on ECGs, we talked a bit about what the T wave represents. So the T wave represents repolarization, and it's partly governed by the movement of potassium. Now, in early stages of cardiac ischemia, when you lose that cardiac myocyte membrane integrity, the first thing that happens is you start leaking out potassium from your cells. This often causes an early peak in the T wave, and over time, once you're depleted of this potassium, it transitions into an inversion. Now, almost all textbooks would talk about inversion being an indicator of ischemia, and this is often because by the time patients come in, they're already past the peak stage and are almost always in a T wave inversion stage. You then look at the ST segment for any elevation or depression, and you also look for new bundle branch blocks. With bloods, you do your troponin C, which is specific to cardiac myocytes. Creatine kinase can also be done, but it's less specific, and now it's not very commonly used in hospitals today. And it's also important to do FBEs and UECs to establish a good baseline to assess their hemodynamic stability, whether they are anemic, whether they might have any infections or exacerbations, and if they have any electrolyte disturbances that might predispose them to arrhythmias. Because as you know, a heart attack puts you at a very high risk for arrhythmogenic activity. In terms of imaging, it's always good to order a chest X-ray to rule out any respiratory cause. You can do a PCI, which is both a diagnostic as well as a treatment. And it has to be done immediately if you suspect a STEMI or a high-risk NSTEMI, and we'll go through what these terms mean. You can also do something called a thallium scan, or more commonly done a stress test. However, this is often done in stable angina to assess the degree of lumen constriction. Finally, you can also do an echo, and this is often done after discharge to assess for whether there has been any, disruptive flow, any valvular issues that might have developed after the infarction, or whether they have any signs of left ventricular dilation, hypertrophy, and also to assess the left ventricular ejection fraction. So going back to our syndromes and what they mean, summarizing them, stable angina is just ischemia. So if you catch this acutely, you might have a T wave inversion. You should not expect a significant trop rise in either stable angina or unstable angina. With NSTEMIs, it is a minor infarction, so you can have T wave inversion, ST depression, and a slight rise in trops. STEMIs are your full-blown heart attacks where everything really hits the fan. So treatment. As you know, for every single condition, lifestyle intervention is your first go-to thing to talk about. But if a patient comes in with a heart attack, it is unlikely that this is going to be your first thing you talk about. So before we jump into that, let's talk about the acute management of ACS. And we can talk about each one of these and what and why we use them. So morphine, as you know, is really good for pain, but it's also a good vasodilator. So by giving morphine, we might cause a bit of vasodilation in the cardiac arteries, and this can often help with reducing the degree of ischemia. It's also important to know that these patients will be in severe excruciating pain, so morphine can really help. Oxygen, if their oxygen saturations do desaturate. Nitrates, it's very commonly used in the management of stable angina, but can also be really useful for acute coronary syndromes. Aspirin, now aspirin doesn't really do much in the short term. However, they will need aspirin long term for the rest of their life if they have had an ACS. So it's quite common for us to just throw it in at the start. And the same goes for statins, because as you know, statins don't act and you don't see noticeable drops in your cholesterol levels for a while. And then heparin, you might use low molecular weight heparin or Clexane or enoxaparin, all different names. And that prevents further clot formation, but doesn't break down clots, right? You also use ACE inhibitors, often for blood pressure, and clopidogrel as part of your dual antiplatelet therapy, which most people following a major cardiac ACS event would require. Stable angina, as we talked about, nitrates, and they often have this in the form of a spray or a sublingual tablet. Aspirin, statin, and ACE inhibitors more so in the long term. For low risk ACS, which is your unstable angina or an NSTEMI, a low risk NSTEMI or unstable angina, it's very, very similar. However, you would not go on and do, I guess, more invasive maneuvers after that. If you do have a high-risk ACS, so you do everything that's pretty stock standard. If it's a high-risk ACS, which means it's a high-risk NSTEMI or unstable angina, or a STEMI, which is already high risk, you do everything that you just did. Additionally, if it's been less than 90 minutes since the onset of symptoms, and if they're at a center that has PCI capacity, you do a PCI. Or if it is been more than 120 minutes but less than 12 hours, you can do thrombolysis with alteplase, which is your clot buster. However, that's only commonly done for STEMIs. It is contraindicated if you have an NSTEMI or if the patient has a history of major hemorrhage, since you risk causing another hemorrhage. Now, you might have heard me talk about high risk versus low risk NSTEMIs, and that's a bit tricky to navigate, but I'm sure we can get that really clear soon enough. So the treatment of NSTEMIs really depends on its severity. The question is, do we reperfuse or do we not reperfuse? And how do we assess that? We use something called the TIMI score, TIMI score, for risk stratification to determine whether they need aggressive surgical intervention or whether medical therapy is going to be sufficient. As you can imagine, the higher the risk, the more likely it is that surgical or aggressive PCI therapy will be useful. And factors that play into account would be their age, risk factors, the use of aspirin, known coronary artery disease, and a few other things that you can go through in your own time. It's not crucial for you to memorize this, but it's good to have an understanding of what you would do if you would have such a presentation. Now, complications. So once you've managed the acute hypoperfusion, you need to also think about, well, what might happen following this. One of the biggest complications, and so a really good acronym is going to be your A, B, C, D, E, F, and the E is a bit of a stretch, but starting off with A, we have our arrhythmias, and the most common and most deadly ones are going to be VT, VF, and asystole. And these are the most common causes of death in patients who have an ACS. Because you have hypoperfusion, you can imagine that the cardiac myocytes are not going to be pumping really well. So you may have akinetic ventricular regions, putting you at high risk for blood clots. You can also have a rupture of the cardiac wall because you have extensive fibrosis now, and the muscle has died. That can cause something called a cardiac tamponade, where, as you can imagine, if you have a rupture in the myocardium, you have a pericardial layer outside that. So now you're going to have blood seeping from inside your ventricles to the pericardial space. Over time, the pericardial space can be so filled with blood in a high pressure environment that it starts compressing on the heart itself. And that can often reduce its capacity to pump by compressing it. And eventually, in some cases, can cause pulseless electrical activity, where your electric system of the heart is functioning as it should. However, because of this high pressure, the actual muscles can't contract. There's also something called Dressler syndrome, which is a pseudopericarditis. It's called a pseudopericarditis because it's not really an infection, but more so it's because of inflammation of the pericardium, because the myocytes or the myocardium that is now dead and being replaced by fibrotic tissue can often be pro-inflammatory as it rubs against the pericardium. EEC is the stretch and it stands for death, which, as you can imagine, is not a fun complication to have. And then lastly, they may have heart failure, which can be acute or chronic. So let's work through a case to tie in together everything we've said. So to finish off, we have 52-year-old Steve who presents to the emergency department with chest pain. Now, just because we've talked about ACS today, I don't want you to just be thinking about ACS. Well, it is going to be ACS, but it's important that we also consider other systems. So what's going through your head? What else could chest pain be? And this is when you use your diagnostic framework, and you can have many ways to go about this. You can use acronyms like Vindicate, or you can go through a systemic approach. I've used a systemic approach for this one. So going through different systems, you can either have the cardio system being affected. So this could be ACS, it could be an aortic dissection or pericarditis. In the acute setting, you could have a pneumothorax, you could have a PE or pleurisy, and it can also be musculoskeletal or costochondritis. That's commonly seen in younger patients, often after extensive exercise. So because we have these differentials broadly in mind, we have to ask our questions accordingly, right? Because at this level, you are past asking your stock standard system review questions, and you want to develop into some more specific questions. So if you suspect an ACS, you want to have a good understanding of what the pain is like. Is it crushing? Does it radiate? Do they have nausea, vomiting? Are they sweating? Have they lost consciousnsterness? Their past history? Is it getting better or worse? All that. Aortic dissection is typically described as a tearing pain that's often retrosternal and radiates to the back sometimes. Do they have hypertension? Because that's one of the biggest risk factors for an aortic dissection. If you suspect pericarditis, have they been unwell recently? And is the pain positional? Quite typically, pericarditis chest pain tends to be relieved by leading forward. If you suspect this might be a pneumothorax, again, you need to assess, is the pain pleuritic? Do they have a history of emphysema? Are they particularly tall? Do they have Marfan's perhaps? If you think this might be a PE, you got to go back to your Virchow's triad and ask questions accordingly. Hopefully you get the gist at this point. So going back to our case, Steve, he describes the pain as sharp, crushing. He tried some GTN that he's used in the past, has not gotten better. It does not radiate and does not have any associated symptoms. He doesn't have anything else that we asked. He did admit to having chest pain in the past on exercise that usually resolves with rest, but this is quite different. And that's a very typical description of stable angina, then transitioning into something a bit more sinister. In terms of medications, he had hypertension, for which he was taking perindopril, and a GTN spray when required for a stable angina. His father had an AMI at 56, and both his parents have hypertension. In terms of social history, I've mentioned this below, but it's not particularly relevant. I guess he has little to no physical exercise and is slightly overweight, and that might be a significant risk factor for him. So what do we do? Well, we take a history, we then go and do an exam. So with the exam, we look for signs of acute onset heart failure. Does he have any arrhythmias? Assessing his fluid status. Do we hear any new murmurs? And if at this point we think this might be typical cardiac chest pain, as I mentioned, we need to go back and order some tests that we know are going to give us a lot of information. ECG, TROPS, UEC, and a few other tests as a baseline. From there, we hope to figure out which one of the ACSs this is. And this is where our ECGs and TROPS come really handy. Going back, I might go through this for this particular condition, but for other conditions, I won't as we go through our lecture series. But I want you to, very commonly in a OSCE or your senior consultant might ask you, why did you order certain investigations? So it's good to be able to understand why are we ordering certain tests. So ECG TROPS pretty straightforward. UECs, if this person is going to have thrombolysis or any surgical intervention, we need to make sure that their renal status or their renal function is adequate. Do they have any electrolyte imbalances that can cause arrhythmias? LFTs, a good baseline to have. BGLs or blood glucose levels, are they diabetic? And if so, are they having an acute hypoglycemic episode, which can mimic certain hemodynamic signs of an ACS? Chest X-ray, because as mentioned, some of our differentials could be seen on a chest X-ray. Aortic dissections can be seen on chest X-rays, a pneumothorax perhaps, pneumonia. So it's really good to do those. And coags. Is this person at a higher clotting risk? If they were on warfarin, what are their coags now? Because remember, if this tends to be a STEMI, we do need or we might consider thrombolysis. And if their coags are insufficient, or if they are at a higher risk of bleeds, this is something that we might not be able to do. So we go on, form an ECG, which shows that he has an ST elevation in V3 to V5. as we know, these are concordant chest leads because they usually represent the same region. And there's an increasing trend on the TROPS. With TROPS, we don't often look at just the one, but often look at the trend of a few measurements down the tract. So this is unfortunately a left anterior descending STEMI. So we start with our Monash AC, our morphine, oxygen, nitrates, aspirin, statin, heparin, as well as our ACE and our clopidogrel. He also underwent an urgent PCI since he presented to the hospital 90 minutes before the start of symptoms, within 90 minutes of the start of symptoms, and also the hospital had the capacity to do, the capacity to perform PCIs. After a week, Steve was feeling much better and is ready for discharge. The question then arises, what long-term medications would you put him on? So statins, a person with an ACS will have statins for the rest of his life, as will be aspirin. Often, depending on their hypertensive status, ACE inhibitors and beta blockers are quite common. And also clopidogrel with aspirin forms our dual antiplatelet therapy. And depending on whether they've had or required a PCI, our durations vary. So if they've had a PCI, it's 6 months that they need to be on dual antiplatelet therapy. And if they haven't, it's 1 month. And that wraps up our presentation on ACS and angina. As always, if you have any questions, please feel free to get in touch or drop a comment. I'm more than happy to answer any questions, and there are no such thing as dumb questions. Thank you everyone for tuning in, and I'll see you in the next one.